But I'd like to now introduce Jamie Sleigh. I think Jamie really needs no introduction. He's Professor of Anaesthesia from Waikato. I think Jamie knows more about EEG than just about anyone I know. And so, Jamie, can I invite you to come up and talk to us about EEG, a window into the brain.
Thanks, Guy. I'd also like to thank the organisers for setting up this session, and I think it'll be slightly different from the usual EEG session. So I think we're quite fortunate in that we live in an era where we are starting to be able to have a handle on how anaesthetics affect the primary end organ, which is their target end organ. And I'll go through in this talk various issues about the EEG and some of its good points and bad points. One of the themes I want to emphasize is that we need to use the EEG to look into the brain, so that the little wiggly line by itself is kind of meaningless, but it is actually giving you some information about what's happening inside the brain. And one of my sort of bugbears is that really it's measuring the cortical activity, and so it should be called a cortical activity monitor, not really a depth of anesthesia monitor. The idea of this talk is to give everyone a little bit of a background to being able to interpret some of the more tricky cases that my fellow panelers will be presenting. So this is really the structure of the talk. Some brief idea about where the EEG comes from and the effect of surgery, and then the important issue of artifacts. So the EEG essentially derives from currents that are occurring in the pyramidal cells in the outermost layers of the cortex. Fortunately for electroencephalographers, the pyramidal cells are all positioned tangentially, like in this picture. And so it's sort of like a crew cut. They're all facing much the same direction. And so therefore, when you get averaging of perhaps 10 million or 100 million of these pyramidal cells, you get a current flowing, which then causes a voltage change on the scalp. Obviously, it's got to get through the skull, which smears the signal quite a lot. So you're kind of you're trying to work out the activity of the brain from a distance. The other thing to remember is that the cortex itself is vastly influenced by subcortical structures. So when you look at the EEG, you are actually often looking at what's happening in subcortical and brainstem structures and how they're influencing the neocortex. Now, a lot of the problems with interpretation of EEG boil down to philosophy. I know it's a pretty sort of flaky kind of thing to say, but you'll find a lot of the issues that occur because we have a poor idea of what anesthesia is. So this is my definition of anesthesia. It's a syndrome. In other words, there's a whole lot of different clinical components to it where we're trying to suppress nociceptive stimulus. And this might include all sorts of components of your brain and body. And we're particularly interested, obviously, in memory and consciousness, but obviously suppression of autonomic responses is probably important in terms of perioperative myocardial infarction. The surgeon's worried about somatic movement. But even perhaps more importantly are issues of hyperalgesia and immune modulation, which quite likely have more effect on long-term mortality than the initial things that we're interested in, like memory and consciousness. So I want to really emphasize that the different parts of your body will have different responses to anesthetics in different people. And I think you'll see some of the cases that are presented are kind of classic cases where the patient moved although their brain was fast asleep. And I think you have to have a very clear idea about what you're measuring. And essentially, it's obviously you've also got to take into account the effect of the surgery. So you can define good anesthesia as that where the anesthesia is completely victorious over the effects of the surgery. Now, we'll mainly concentrate on the effect of anesthesia suppressing consciousness, just in the interests of time. And again, we have to think about how is anesthesia causing unconsciousness. And in recent years, there's been quite a lot of work in this regard. And it seems likely that this is largely due to the fact that it's causing disintegration of your cortex. So bits of your cortex are not talking to each other the way they would be when you're conscious. There's a further complication that sometimes you can be conscious but disconnected from the world in a delirious or dreamlike state. So we'll start off with a sort of simple idea. Most of the drugs we use commonly in anesthesia have a GABAergic effect, which causes hyperpolarization, and this is relatively easy to see in the EEG. So these are a whole series of different drugs where someone has measured the EEG and intracellular recordings inside cortical neurons. And we can see in the wake state, the EEG is small and fast. And when we see that small, fast waveform on the EEG, we must kind of have this little mental image in our mind that the cells are in an up state. They're firing away happily at perhaps somewhere between 2 and 20 spikes per second. And it's associated, they're a bit depolarized, it's associated with being conscious. With increasing anesthesia, and you'll see this is ketamine xylazine anesthesia, so not strictly GABAergic, but it clearly shows that you get periods where the neurons are hyperpolarized. These are so-called down states. And you can imagine you're tending to lose consciousness, your consciousness is beginning to break up. And this is a barbiturate anesthetized animal where there's a lot of down states, which is associated with unconsciousness. Now, this kind of sounds a bit like kind of esoteric neuroscience, but I think it's really important when you see those wiggly patterns on the EEG waveform, you must kind of asking yourself, what are those cells that are producing these patterns? What are they doing? So this is an example of a awake EEG and a depolarized. This is before the patient becomes anesthetized. And these are the big slow waves that you see when the brain's hyperpolarized, particularly the thalamocortex. And the commonest pattern that you'll see during normal general anesthesia is a mixture of so-called alpha waves and delta waves, and it's the signature of thalamocortical hyperpolarization, and as such is a pretty good indication that the patient is unconscious. So these are the delta waves I've shown in the little red line there, and on the right-hand side, you'll see the power spectrum. So that's a diagram which shows the frequencies on the horizontal axis and the power on the vertical axis. And so you can see these red delta waves have a frequency around about 1 or 2 hertz. Superimposed on that are these spindles, which you can see between the delta waves. I've just scribbled them in there. And they correspond to the peak in the power spectrum of usually about 10 to 12 hertz. So this is an example of the sort of patterns that would occur when a patient's getting some propofol. So the top line is just the raw EEG, and it shows basically small fast waves and then these occasional blinks because the patient is a bit anxious. As the patient becomes anesthetized, they move to the second line. You can see the waves get bigger and slower, and in fact they become unresponsive to verbal command around about where the B for bigger is. As the propofol brain concentration increases, you start getting these bigger slow waves called spindles and delta waves. And in very deep anesthesia, you might get a burst suppression pattern. So that the top line shows the raw EEG, and you can see there are periods where it's kind of more or less a straight line, not particularly straight in this case, and then interspersed by periods where there's big bursts of activity, perhaps every few seconds. The bottom I've shown is a thing called a spectrogram, and I'd like to introduce the idea that looking at a spectrogram is a very useful visual way of seeing what's going on with EEG and anesthesia, and it would be nice if it was more available in the EEG monitors. Essentially, it shows the frequency on the vertical axis and time on the horizontal axis, and the color is the amplitude or the power in each frequency. And so this shows burst suppression, which shows these kind of vertical stripes of high power activity interspersed with the blue, which is the low power. So I've put the case for thalamocortical hyperpolarization. I will put one big proviso, and that is that it is quite common for people to be unresponsive even with a depolarized looking EEG. And so this is somebody who's waking up at the end of an anesthetic after sevoflurane anesthetic, but they're not responsive to verbal command yet. They're just kind of sitting there and you yelling at them to open their eyes so as you can take out the tube and go home for tea. And we can see it's quite a wakeful looking EEG. It's just small, fast waves. And that there's not much sevoflurane still floating around in the brain. And that they're gradually getting an increase in their sympathetic tone, which in this case is measured using the GESPI, but there are various other ways of estimating sympathetic tone. And quite a highish state entropy. So think of the state entropy as kind of more or less similar numerically to the BIS. They're not identical, but there's a lot of similarities. Anyway, this is a person who's kind of practically awake but not responding. And they're classically the ones that are in a sort of dreaming state. So you have to understand these people they do have a sort of consciousness, which is what the EEG is telling you, but the consciousness is not connected to the outside world. So I'll go through a few examples, and you can see how you might think about using the EEG. These are kind of like practice examples, and then later on there'll be the proper ones that you vote on. So one thing in the use of the EEG is you can sometimes give very small doses of anesthetics, and that's quite appropriate. So again, this is the power spectrum, which has time on the horizontal axis and frequency on the vertical axis, and power is the color, where red and yellow is high power and blue is low power. And you can see this is a person who's had quite a good anesthetic with 2% desflurane. They had a low BIS, they have quite a classical anesthetized sort of pattern, they're completely unaware. It all went fine, but I'm not sure there's many in the audience would give a 2% desflurane GA to healthy people. We can see at the end there's a period where, like the previous slide, where they lose their spindles and their delta, and they're in this sort of REM-like small, fast wave state before they wake up. This is another example of a patient who was 80-year-old who was malignant hypothermia susceptible, so he had a TIVA anesthetic, and he was particularly worried about awareness because the people at the RSA club had been rocking him up about how he's going to be awake during his anesthetic. And you can see he had a classical-looking EEG and a low BIS, even though he was only getting 2 milligrams per liter TCI of propofol. This is another case of a person having a hip joint replacement, again with not a huge amount of anesthetic, but perhaps appropriate for the age. Conversely, there's a few people that are pretty resistant to anesthetics, and you'll see a few classic examples a bit later on. And so here's somebody who had a BIS of 60, which is kind of right on the upper limit of where you'd be generally comfortable, but needed an end-tidal desflurane of 7.6% to achieve this. Again, had quite a happy-looking EEG pattern. This is a patient, an 80-year-old, having a craniotomy for a subdural with a bit of remifentanil and a little bit of desflurane. And you can see, this is obviously a screenshot. It shows we're giving a modest amount of desflurane because we don't want to vasodilate the brain too much, that they have quite a suppressed sympathetic system and a good-looking EEG. A bit later on, we turned down the desflurane to 3.1%, and we found that some changes which I'll show here. So first I want to draw your eyes to the yellow arrow with the question marks, because obviously when you're placing the electrodes during craniotomy, you have to often put them in kind of illegal positions. And so I had to switch off the automatic check. So that's the first thing. We haven't got our normal check of impedance. So always you have to then take the EEG with a pinch of salt. We're not sure that we're getting an accurate signal. Anyway, we can see there was a big gap between the state entropy and the response entropy, which is an indication of increasing muscle tone with the DES at 3.1%. And so essentially we just turned the DES up a little bit and the patient became more relaxed just by increasing the anesthetic. Some people really don't like making that spindles. They just have a delta pattern. They're about 10 or 15% of the population. And presumably this is to some degree because of their genetics. So essentially I think when you're using the EEG, instead of saying we particularly want to target a certain range, we want to ask a slightly more general question: have I given enough anesthetic to maintain unconsciousness in the face of whatever the surgeon is doing? So to answer that, we have to have a bit of an idea about what noxious stimuli do to the EEG. Now this is a little diagram that I've made to try and separate in my mind different components of a patient responding to some sort of painful stimulus. And I think it's important to separate the stuff that's going on in the brain stem, which essentially is activation of natural sleep patterns, from what the anesthetic is doing at the cortical level. Now the reason why I bring this up is that in natural sleep you tend to be either awake or asleep. You have systems in your brain that will force you to be completely awake or completely asleep, although after last night there might be some exceptions to this rule in the audience. Anesthesia kind of blurs this because it's acting partly on these intrinsic sleep mechanisms and partly on other mechanisms. And so, as you'll see classically later on when you're using anesthetics to cause a bit of sedation, you're generally activating the sleep pathways without really blocking the nociceptive input, which then causes the patient to suddenly wake up from what was apparently quite a deep state. And I'm sure everyone has seen that in this audience. So the most common pattern you'll see when the surgeon starts cutting is no change, and that's an indication that you're giving a decent anesthetic. And part of the issue of the EEG is people say we don't need to do it because we can give a decent anesthetic anyway. And that's true. I mean, you can sail a boat without a compass most of the time, quite happily. But every now and then you need to know information from the compass to help guide you where you're sailing, what direction you're sailing. And you need to know stuff about the compass that is pointing to magnetic north and not true north, etc. Anyway, so this shows basically no change, and we think that's probably what we want to do when we're giving anesthetics. Occasionally you'll find that you lose your delta waves in your spindle. So before the incision, the response entropy was 49, and you had these delta spindle kind of pattern, which is the top graph in the figure. Surgeon starts cutting, you can see the delta amplitude goes away, response entropy goes whizzing up. And what would you do in response to that? You're sailing pretty close to the wind with that small, fast EEG. I think you can make a good case for deepening your anesthetic. Sometimes you just lose the spindles, but perhaps not so much for the delta. And so there you can see the peak of the spindles before the surgeon started cutting. Afterwards, it caused a whole lot of depolarization to happen that took away the spindles. If you see that happening, it's kind of, again, probably you can make a good case for increasing your anesthesia, or at least your analgesia. This is an example of a 35-year-old fit, healthy bloke having shoulder surgery. And we can see that there's a particularly painful bit of surgical manipulation that involved the acromioclavicular joint. And it caused, as you can see in the second line of that graph, a decrease in the alpha waves, which are the spindle waves, but not much change in the delta wave. It's an indication that the extra pain of the surgery is causing some depolarization in the thalamocortex. Interestingly, you see there's no change at all in the heart rate. And because of the loss of the spindles and no change in the delta, the entropy value went down. In fact, that's an indication of inadequate anesthesia, so it's a completely opposite direction from what you'd expect. You expect if the surgeon started cutting, the entropy or the BIS would go up. But this is a paradoxical situation where the patient's becoming lighter and the numbers going down. And these are just the raw EEG traces before and after that. So in the cases to come, there'll be kind of this sort of choice as to how you might respond to these sort of situations. Now you'll find giving extra opioids often has quite a strong effect on the spindles. And so this is giving an extra bit of fentanyl. We get increased spindles, we get a bit increased delta power, and there's no change in the entropy, even though we've decreased the desflurane slightly. Ketamine's a different drug that acts in different sort of ways, and sometimes doesn't really change the EEG much, but quite often will put it up. And so this is after giving 30 milligrams of ketamine. We can see that it increases the high frequencies, although in fact the anesthetic has become deeper. Similarly, nitrous oxide. So this is a patient who's having hip replacement. We can see we're running quite a high response entropy of 66, which is kind of above the recommended range, and you could argue perhaps we might want to try and increase the anesthetic. But in fact, if we look at the anesthetic delivery, the patient's getting 1.1 Mac of anesthesia. They're showing no signs of autonomic activation, and the raw pattern looks okay. So therefore, I'd be quite happy to carry on, even though the entropy, which is kind of similar to the BIS, is kind of above what's recommended. This also shows that the central nervous system and the cardiovascular autonomic nervous system can be quite different. And so this is a patient who's having quite a deep anesthetic, but had an increasing systolic blood pressure. Now, I introduced the idea of the propofol ping. So if you're kind of not really sure, you're not really trusting the EEG montage, quite often a useful thing is to give a little bit of propofol. And you should see a kind of appropriate response. And so the top graph shows the raw EEG before the propofol. Afterwards, we get a burst suppression pattern, which is an indication that that wiggly line that you're seeing is actually telling you something about what's going on in the brain. The various indices, the common ones are the BIS or the entropy, essentially measure the shift to low frequencies, have some incorporation of burst suppression patterns, and are very good at rejecting artifacts. But you have to know about artifacts. For classification, in my mind, I separate them, those outside the head, which are usually electrical interference. That's involving the head, which is usually EMG, and then occasionally there's other pathology in the brain that you mustn't forget. So this is an example of outside the head. Before the diathermy, the BIS was 42. After the diathermy, it went up to 67, but there was no underlying change in the raw EEG, and you shouldn't particularly respond to that. Where you work is a blizzard of electrical noise. This is an EEG from one patient, but I was able to look at the actual raw signal. So this is the EEG that appears on the screen, but actually what's going on the monitor looks like that. So I think if you're aware that you have this huge amount of noise, you have to always have that as a confounding factor in the back of your mind whenever you see some unusual or abnormal kind of result. So this is an example of a patient having a AAA, and they've got a entropy of about 80, which seems particularly high. But we note they're getting 5.1% desflurane, so they're getting quite a sufficient amount of anesthetic on board. And you can see these funny little spiky things in the EEG waveform. In fact, we also see them in the ECG waveform, and these are just mysterious and unidentified electrical interference from unknown sources most of the time. Similarly, the EMG has got a much bigger amplitude than EEG and will mess up your EEG. And so there's someone who had a BIS of 65 and we gave a muscle relaxant and went down to 34, because we can see the underlying EEG waveform is consonant with the patient being quite well anesthetized. And so this is kind of an example of someone, they've got a big difference between their state entropy and response entropy, which is an indication of a lot of EMG activity. Everything else kind of looks okay. And so, would you do nothing? Would you increase the anesthetic? Would you give a relaxant? In this case, we gave a relaxant, and we can see that the entropies came back down to normal. But you can see, obviously, if you're going to give a relaxant, it's kind of a little bit tricky. You've got to be 100% sure that that you should look at the underlying signal and be reasonably happy the patient's kind of asleep. And B, after you've given the relaxant, the patient should be clearly asleep. You could imagine if you gave the relaxant and the entropy stayed at 80 or something, it would be an indication to quickly give some more hypnotic. Often you can't see the EMG very well on the screen, and so with the GE, you look for the difference between the state entropy and the response entropy, and for the aspect system, it'll give you the EMG as an independent measure. In the brain, you occasionally get seizures, which will mess up what you think the EEG should be, but often you should actually try and respond to some anti-seizure maneuver. So I put this as the sort of final slide before we get into some of the cases. Essentially, I think we must just be aware that EEG is good for cortical activity, but no good for movement or autonomic systems, and that you should look at the raw signal in order to interpret the number. And the last thing is really always consider the number, and sometimes the raw signal is going to be messed up by numerous artifacts. So I'll stop there and hand it back to Guy.